Thank you, Paul. And thank you, Dr. Bruce, for also a wonderful and very practical, informative talk. So we are going to go directly into our panel discussion and finish off the day with an expert panel. We will use some of the questions that are left over from the Q&A and build on those in our panel discussion. I'd like to introduce two additional members of the panel, in addition to the speakers we've had today. The first is Dr. Susan Swindells, who is a professor of medicine from University of Nebraska, and Dr. Monica Gandhi from University of California, San Francisco. I'm sure most of you recognize them and know of their wonderful accomplishments. I won't go into great detail to review those for you, but they are both very experienced practitioners in HIV medicine and highly regarded investigators in many of the aspects of what we've talked about today related to HIV. So let's go right into the panel discussion. We've got a number of things to discuss that are left over from this morning and the day's discussions from our presenters. And I'm going to start off with a few of those, but also touch on some concepts that I want all of the panel members to discuss. And I think the first of those has to do with maybe a very broad question that can apply to many of the topics that were discussed today and include expertise of our panelists. So what tools do we have besides antiretroviral therapy in our people living with HIV to reduce inflammation? A lot of us have been involved in studies of anti-inflammatory interventions. Dr. Valcour mentioned statins, as did Dr. Feinstein, but let's go with that broad question and hear from our panelists. What are you using to try and bring inflammation under better control in your clinical practice? So maybe we can start with Dr. Gandhi and Dr. Swindells, since you've just joined us.
I would say that I am waiting for the RECLUDE trial. I don't think that we know yet about the low dose rosuvastatin and the other one.
Yes.
Yeah, and I am waiting for that because clearly there was a lot of movement by all of us to put on aspirin and statins sort of prophylactically without good data on that. And then aspirin became, concerned with risk of bleeding in older patients. Statins became risk of diabetes. And so that combination means I think we need the data, we need the RCT.
And so Victor and Matt, you both have been heavily involved in looking at the effects of anti-inflammatory agents on your respective organ systems. What are your thoughts on this question?
And maybe Doug Bruce, too, in terms of the role in pain control.
Yeah, I was going to get to that. So.
Okay. I said we haven't coordinated this.
So, Victor, how about you go first?
Yeah, I know that there have been some smaller studies, and I think probably ACTG has done some as well. I'm not as familiar with them, and certainly in my practice, it's not something that I prescribe. I haven't seen large effects. There's been quite a bit of work done in the non-HIV field around anti-inflammatories and Alzheimer's disease. And most of the time, it's similar to what you're saying, very small, if any, effect size and high risk. At one point, there was a study of prednisone, and there have also been non-steroidal anti-inflammatories. And so these aren't without risk in older populations. I'll say kind of anecdotally, and maybe just slightly more than anecdotally, I've had patients tell me when they get treated for H. pylori, they feel better. And that doesn't necessarily surprise me because I wonder about gut translocation. Because we have very little immunologic barriers, within the first month of HIV infection. So there's a higher risk for microbial translocation. And there have been some small studies that show higher soluble CD14. correlating to cognition. So you have to wonder if there might be a gut approach to this. I've talked with one of my colleagues, Lish Nedlovo, who's now at Cornell, about whether we should be testing this and looking at it more. We've done a little bit of work in Africa around this and find signal in both HIV positive and HIV uninfected people, which is also not surprising given some of the parasitic burdens that exist in some of those populations. So I think that's the most intriguing thing for me right now, is whether we should be thinking about that.
Yeah, and I would tend to echo the overall concepts that you're starting to, I think, enumerate there, Victor, in the sense that I think the further upstream we go to the source of this, when we talk about inflammation, we often talk about it in a pretty non-specific way, but to actually look at the sources, I think that gives us a much better chance of getting these substantial effect sizes where the positive signal is going to outweigh the negative noise, right? So, and I agree, Monica, I agree with you too in terms of the statin question. Statins are not the most potent anti-inflammatory agents, but they seem to be pretty well tolerated. I think there's a good chance they would help. I don't think they're going to be the anti-inflammatory hammer. And I think a lot of it is, this is, I guess, kind of obvious, but I think our best anti-inflammatory agent is early therapy, people not dropping their CD4s, not having persistently elevated viral loads. Just because there have been a lot of recent trials in the cardiovascular space about anti-inflammatory agents. So maybe I can just go over kind of my take on these really briefly, because it might be of interest. There's the CANTOS trial, which was canakinumab, an IL-1 beta antagonist. I think the results in terms of the trial and the real world sort of highlight some of the potential issues with relatively broad anti-inflammatory therapies. It does target IL-1 beta, so in that sense, it's not prednisone. It's not something along those lines. It was a positive trial, meaning it resulted in about a 15% relative risk reduction in cardiovascular events in a kind of a pro-inflammatory population with cardiovascular disease. But and it's off-target effects where it had a trend towards a potential benefit in terms of reducing heart failure risk as well as potentially cancer risk. There weren't a ton of problematic infections, but there were somewhat more infections in the treatment arm. But it's super expensive, and the effect size in absolute terms is really small. So despite being a positive trial, the FDA, I think, in my opinion, appropriately, did not approve it for a cardiovascular indication. And so I think that really highlights. And then we've had other trials. We had a negative trial of methotrexate for looking at cardiovascular endpoints. There have been a couple of positive trials of colchicine in people with cardiovascular disease, which is interesting. The GI side effects have been potentially problematic. The mechanism it's thought to be a microtubule inhibitor, so it's almost like chemo level stuff. But that's a really long way of saying my take on the anti-inflammatory space for cardiovascular disease right now is either if it's something that's really targeting a cause upstream of the more inflammation, in which case for HIV in general, it's early therapy. I think that's likely to be effective. Or I think if it's kind of like secondary prevention, so immediately after a cardiovascular event, let's say post-MI or post-initial heart failure, when you have that vulnerable period where your anti-inflammatory signal and the benefit of starting that drug might outweigh the side effects of the noise. That's where I could realistically see it going, rather than, at least at this point, a broad anti-inflammatory, because I think there's just too much noise there.
Okay, I think those were both great questions. I think we got to make them a little shorter answers so we can get to everything. Paul, you want to take the next one?
Sure. So let me, this is a very specific one, but I think important. If your clinic doesn't have access to really good HIV oriented psych services, talk a little bit about antidepressants that you do once you start, once you've done a screening. Comment on that. I think I could go to Steve, perhaps, or.
And maybe we can ask Charlie to weigh in on that question.
Actually, let me start with Susan Swindells. I'd like to get her in on this. Do you want to start tackling that?
So,
what's your favorite antidepressant if you don't have a lot of access to psych services?
Yes, I have a very short list because I already know like a couple that don't have very many drug interactions, and that maybe I can remember the dose of, and so I
think a lot of us are in that position.
So my expertise here is pretty limited. I'll often offer that to a patient and give it a few weeks and see if it does make them feel better. It doesn't always, a lot of times people just have sad lives, especially now. It's been such an awful year that, I don't think any amount of SSRI can fix all of it. But we're fortunate that we do have access to psych services, but oftentimes people have to wait a really long time too, which is by no means ideal. You refer someone and they get an appointment for sort of 10 weeks later. Well, what's the point of that? But they're also incredibly busy. So yeah, I think it probably behooves us all to just get familiar with one or two and get comfortable with it. And personally, I don't feel that competent to get much more complicated than that.
Charlie, do you have a recommendation?
So several sort of general comments. Comment number one is, how do you know when someone with depression actually needs an antidepressant? And I think you need to be very careful about distinguishing reactive depression from organic depression or psychotic depression. So that's kind of a general medicine comment. The irony is that organic depression is easier to treat than other forms of depression and should respond to effective antidepressant therapy. What I have found is that although the newer antidepressants may be more effective and they had different side effect profiles, third-party payers may be reluctant to pay for them. So you're going to be stuck with who's the third-party payer and what are they willing to let you prescribe. And you may be stuck with an earlier generation generic Prozac or something like that, which, by the way, can be quite effective. They just have a different side effect profile. And then the other pharmacologic principle is always give the antidepressant enough time to act. It can be 4 to 6 weeks before you really begin to see benefit from an antidepressant. Certainly, you can see significant effects within 2 to 3 weeks. Often what you see in someone who's organically depressed is they start to complain because they finally have enough energy to complain. They tell you, oh, I'm really not feeling better. Oh, I still don't want to eat anything. Well, what'd you have from last night? Well, I had a T-bone steak and some rice, but I really didn't want to eat that badly. So, when they start to feel well enough to complain, the antidepressant is working. The other sort of general comment is I'm increasingly impressed by the impact of effective antidepressants on temporarily increasing suicide risk, particularly in younger patients. So be very careful about starting antidepressants in teenagers and young adults, because one of the things antidepressants do is they give you enough energy to carry out the things you didn't previously have enough energy to do. And so if you're going to start antidepressants in a teenager or young adult, make sure they're in a setting where they're going to be watched all the time, like even at night. Don't give them the option to go into the closet and hang themselves, because that is a tragic outcome of effective antidepressant therapy. And we see this all the time.
Okay, you're really upbeat today, Charlie. Thanks.
Sorry, you gotta be realistic for people who don't have access to psychiatric services. This is what the psychiatrist.
One other thing that can be helpful though also is the PHQ-9 is validated for repeat measure, and so if you don't have a psychiatrist or a therapist who's monitoring this, right? Charlie's point is important. don't repeat the PHQ-9 a week after you started the antidepressant, right? But you should be rechecking it. That's going to be another way to validate that this treatment's getting better. And is something, actually, there have been studies in Africa that just use the PHQ-9 as instructions on how to taper up the antidepressant.
And Steve, yes.
Yeah, I
get the final word on this question because we're going to go on to another one.
Yeah. I mean, I think our group has some kind of basic knowledge of using common things like sertraline or fluoxetine or bupropion or things like that. But because we have integrated mental health services, we often still have kind of curbside consultations with them. And we've also, in a couple instances, programs in our state that do not have mental health services, we've been able to provide telehealth consultation for them. And so I feel like people that probably have a significant population of people with HIV ought to be able to negotiate some type of relationship like that where they can actually get mental health advice. And we've learned during Zoom that in the epidemic that telehealth is actually pretty good for mental health care.
Yeah. The only thing I want to add is the long-acting antidepressants and antipsychotics and how interesting that is put together with long-acting antiretrovirals. So we have a pilot going on here about people with psychotic depression and injectable antiretrovirals and putting paliperidone with our cabotegravir rilpivirine. So it's going to be interesting that we now have these options.
Triple combo.
Yeah.
Connie?
Okay. I'm sorry, go ahead, Paul.
No, I was going to invite you to.
Okay. So there have been a couple of questions sprinkled throughout all of your talks, and I will say I've been struck about how much each of your topics crosses over with others that we've had speaking today. So a lot of these questions can be things that spill over into your various topics. So one of these is the impact of dual antiretroviral therapy versus triple antiretroviral therapy on some of the things you've all talked about, in particular, frailty for Kristine and neurocognitive deficits for Victor. And are there things that we need to pay attention to in terms of the specific antiretroviral therapies?
I saw one question in the chat, and I've had a couple patients who say to me, I've been taking my antiretrovirals like this for a long time. I've never had any problems. And they're telling me they take them like Monday through Friday, or they'll skip every other day. And they say, actually I had one patient who took it for 2 weeks and then didn't take it for 2 weeks and told me that he's always virally suppressed. And I had to ask, when do you test whether you're suppressed or not? Those all bother me because I don't think we're having a constant pressure on managing the virus, and it could be causing more inflammation. The people that come in on dual therapy versus triple therapy, unless I just think about it, but I've never really made a recommendation one way or the other, because in those cases, I've seen CD4 cell counts are high, viral loads are suppressed. You can look in the chart and see that they have been. And I don't know if there's good data. There may be others on this call that know better. Scott Latonder probably knows this better than anyone else. But I'm not sure there's data that should, in the setting of clearly virally suppressive antiretrovirals, that 2 is going to make it different than 3 if you're clearly viral suppressed. So maybe somebody else can answer, but that's been my experience.
And I can just add one thing to that, which is the 5353 trial did look at dolutegravir 3TC alone to just check if it was in some way there were increased reservoir measurements with the dual therapy versus triple therapy. And no evidence of like HIV DNA levels being up or Foreman markers of reservoir measurement. So I think that was my most reassuring look, that we may not have ongoing deep replication with the dual therapy in 5353.
Well, it integrates almost.
How about Kristine? Any thoughts on incidence or outcomes or progression of frailty? Any related to numbers?
We haven't seen any studies looking specifically at 2-drug versus 3-drug for frail individuals. Although in general, one of the big components or one of the big risk factors for progression of frailty is polypharmacy. And so I think in general, the more medications we can decrease if we still have the same efficacy would presumably have better outcomes.
So, Connie, this is Sue. If I could just pitch in,
Sure.
I've been thinking more about two-drug therapy. I'm still a bit nervous about it initially, but for people that are doing well, like Monica says, the data is all over, pretty reassuring. And so, for just sort of anecdotally, a few patients that are on an abacavir-containing regimen, mostly because they've got some renal disease. You can take them off that, leave them on dolutegravir 3TC, and they live happily ever after. And maybe this is helpful for their cardiovascular risk. And I would like Matt to tell us all once and for all, how much does it matter about abacavir? Do we need to stop it? Do we need to avoid it? What is the answer? This question will not go away.
So I guess to give a short answer, the short answer is somewhere between I don't know and if there's an alternative that will work reasonably well, just do it. I mean, I think at this point there's enough. There have been enough studies on abacavir that are either neutral to suggesting some degree of harm, and again, the absolute harm relative to others is small, right? So I think for someone who's got no other options for whatever reason, it's still obviously far better to have them suppressed. But no, I think if there are readily available alternatives that are acceptable to the patient and accessible, I think it's probably fair to say it's be a better place to start. But it's the problem with observational studies using a medication as the exposure, because you're never really fully able to address some of the confounding by indication or other factors that are involved.
Okay. Paul, you get the next question.
Well, I want to ask a really specific question for Victor, just because it's been in the news. The FDA recently approved a drug for Alzheimer's. Is this a hot new thing we should all be rushing to try? Have you heard of any outcomes yet?
Well, I was snickering when Matt said, it's an expensive drug that doesn't have good efficacy, so we didn't approve it. Because the FDA in your time,
need an FDA director. Sorry,
they've seemed to change their rules to find a medicine that is going to break Medicare if even a third of people with Alzheimer's disease choose to take it, and has an equity lens that is as terrible as one can imagine. At $58,000 a year, with the added cost out of pocket, that's going to be somewhere between $15,000 and $20,000 in a study that didn't initially show any efficacy in a number of different places, and then in a very specialized analysis of high dose showed that it did seem to decrease the amyloid burden, but not having meaningful outputs. So most of us are scratching our head as to why this would have been approved, and why agencies are supporting it. I think is because it's probably, Paul, like HIV in 1987, when somebody said, take 5 hands full of AZT and I might be able to do something. That's probably the best analogy that I can think of for a disease like Alzheimer's disease, where it's basically, a terrible, terrible outcome, and people are desperately seeking therapies. So I suspect I've already had calls that people want to do it, and yet I don't think it's the right thing for us to have done as a government. I doubt other large agencies like Europe and UK are going to approve this, and it'll have a lot of downstream effects, I'm afraid.
And yet we still don't have an approved COVID vaccine, right?
Yeah. Good point.
Connie, back to you.
Okay, so I'm going to maybe get back to Kristine with another question. This might be too broad a question to ask, but the polypharmacy that Dr. Flexner discussed, and that in a very elegantly outlined us all different kinds of ways that polypharmacy affects us. How do you measure or account for polypharmacy in all of the studies of frailty and progression of frailty? If you just stopped all those one-time drugs that Charlie talked about, would you see improvement in frailty and its progression?
Yeah, that's an interesting question. I think polypharmacy likely contributes to the progression of frailty. However, managing comorbidities probably helps decrease comorbidity or decreases frailty. So I think there's a balance of trying to minimize disease progression, treating diabetes, keeping hypertension under control that may help to decrease some progression of frailty, but at the same time avoiding medications that may have additional neurotoxicity, for example, increase the risk of falls. Some of those criteria or some of those medications on the higher risk criteria list are probably at the greatest risk for progressing frailty. So I think it's a careful going through the medication list with each patient individually, cutting back those medications that maybe aren't having added benefit. And there may be some trialing of what if we try to decrease some of these medications to actually feel better. I think the other issue with polypharmacy is that we oftentimes end up with a cycle of treating the side effects of other medicines rather than treating a new condition. And so if we can decrease some of them that maybe were initially started more for treatment of side effects, that might have added benefit as well. So not a clear answer. I think it would be wonderful to have a study where we could actually try stopping medications. In part, I think it's hard to convince patients to stop medications too. They feel like a lot of them are ones that they need to be on, and it's hard to convince them that some of them are okay to stop. Charlie probably has more to expand on that though.
I mean, I do. Maybe it's ironic that the pharmacologist would be advocating for non-pharmacologic interventions, but you think about things like inflammation. The best thing you can do for inflammation in any patient is to get them to stop smoking. And that's the one proven cause of the worst kind of pathologic inflammation there is. And why on earth would we be thinking about giving someone an IL-1 beta antagonist if they're still smoking? That and I think regular exercise. There's a number of studies showing the benefits of regular exercise on your state of pathologic inflammation. But in terms of polypharmacy, I do agree with Kristine that in a patient with frailty, you really need to contextualize it and understand what's contributing to what. Undoubtedly, I think there are patients where their frailty is being made worse by, or even perhaps caused by drugs that they've been given. But I think you can't. I think you have to try to individualize, personalize therapy there, and assess the individual and see what they're taking and how it might be making them worse.
So I want to stick with Charlie. Sorry, everybody else. But question that has concerned me. I got burned recently with a patient who had a blip, and I was notified by our astute pharmacist that he had started multivitamins with cations, and he hadn't been kind of informed about the need to separate that. Just comment on over-the-counter medications and the challenge that might represent, and just be alert.
It's a big problem because, we tell people not to take magnesium with integrase inhibitors, but no one ever imagines that their multivitamin contains enough magnesium to make to limit the absorption of their integrase inhibitor. So again, I treat multivitamins like I treat anything. I read the ingredients. Not all multivitamins have a lot of magnesium in them. Some have no magnesium, but those that do, you got to treat them like a magnesium supplement. You can't take them with your integrase inhibitors. Honestly, I mean, you probably don't want to hear this from me, but my father, who was a physician, used to say that multivitamins were made for one reason and for one reason only, and that was to make money for the people who make multivitamins. Most people who eat a normal diet don't need a multivitamin. What's the point? There are just so few patients who actually need to take a multivitamin every day. So that would be one way I would approach that.
And I would add even those supplements, like those zinc. There's a lot of zinc in those protein type of things that you take for exercise.
That's to prevent COVID, Monica.
Yeah. Oh, okay. Okay.
Okay, I think our next question we're going to throw to Dr. Bruce, and maybe Charlie will have some comments about this as well. If a patient is stable on a very high dose oxycodone for pain and hasn't had any overdose or drug use or abuse issues, can you continue them on high dose oxycodones? And this is a very practical question, since the person posing it is inheriting a patient who's been on 30 milligrams 4 times a day of oxycodone. What would be your advice?
Well, I would say that's actually not high dose relative to some of the things.
I think that would kill me.
Yeah. I got a call about a guy on 800 milligrams of methadone once that made me very anxious.
Oh my God.
That was a slight problem. So one of the things I worry about is things that are dosed at those intervals. One, I worry about it behaviorally. If you're a heroin addict, you dose every 6 hours. And so if what we could be doing in the patient is reinforcing something that's not a good behavior relative to history. Now, if the person doesn't have a substance use history, I also just worry about it because I found over time that some patients, and I still find this fascinating, and maybe Charlie can explain all the pharmacology, is that we have a fair number of patients who actually start to have more pain as they're on these kind of shorter acting repeat dosing. And my preference would be in a patient like this to migrate this person to something that's longer acting. So whether that's a fentanyl patch, whether that is actually moving them towards buprenorphine, which I like. I even like lower dose methadone, dosed a couple times a day. So there are a lot of options for this person. It's also, I think, really telling in the conversation that you have with the person. And so people who are very wedded to things, I also get a little bit anxious about. Sometimes you get wedded to it because you're in a lot of pain. This works. Don't mess with it. Sometimes you also get wedded to things because of the secondary gain associated with them. So summary, I'd move them off. I'd find an alternative, but it will be a process. It doesn't happen fast.
And that kind of answers one of the other questions about the use of buprenorphine. Is that a good first line drug for chronic or acute pain management?
Well, it has an indication. Suboxone does not have an indication for pain at all, right? But buprenorphine has been in use for anesthesia for a long time. I would not use it for acute pain. We do use it in chronic pain with people who have an opioid use disorder. Using buprenorphine, like using Suboxone to treat pain in a non-drug user, is way off the reservation relative to what the FDA indication is for it. That being said, it certainly has a lower abuse or overdose risk than oxycodone does, or methadone.
Great. Okay, Paul, you get the next one.
Yeah. So, Kristine, somebody mentioned exercise, and I know that you have done some great work with exercise in HIV populations. Do you want to talk about what strategy you have to try to get a couch potato back up on his or her feet?
Yeah, that's a challenge, I think, in everyone, is getting the couch potato motivated. I mean, I think the main thing is baby steps. It's trying to get behaviors that people can stick with all the time, not going overboard and doing fad diets or the newest, greatest exercise move and buying their Peloton if they're not ready to commit to it. So I think it's starting with small behaviors every day that can become a habit. We actually published a couple of years ago an exercise prescription specific to people with HIV and AIDS. And there's a PDF that providers can print off, and it has some tips for starting with 5 minutes a day, starting with 5,000 steps a day, kind of having a goal, and then readdressing it with your patients every week or every 2 weeks, trying to do frequent check-ins and have them slowly increase those behaviors over time to try to get to that goal of 30 minutes, 5 or 7 days a week as possible. Some of the newer recommendations have increased our exercise goals for how much moderate and vigorous intensity exercise are recommended. So I think the more exercise, the better. And then they also, some of the more recent guidelines, the World Health Organization and the CDC have really emphasized the decrease in sedentary time, which I think became a huge issue during COVID as everyone is stuck at home. So little behaviors, reminding people it doesn't have to be 30 minutes in a row. It can be 10 minutes here, 10 minutes there. little short walks throughout the day, especially if they're not in very good shape. Going out for a 20-minute walk can be kind of daunting. So starting with those small behaviors and then gradually increasing. There is some data in the cardiovascular literature that writing a prescription for patients can help. So if you actually prescribe them exercise, there's a little bit more emphasis that patients might put on that than if you just tell them you should really exercise. So that may have a little bit better take with people in terms of following recommendations.
That. Of course, we would medicalize that in cardiology.
Make it into a prescription, yes.
So, make it into a schedule. Make it into a Schedule II drug, and then they might be even more likely.
Yes, you have to come in to get your prescription once a month for exercise, or else we won't give it to you. So, and
you have to walk from the parking garage.
Yes, the far end of the parking garage. You have to take the stairs too. So, yep. So, I mean, those are some minor things.
I just want to make sure that Kristine thinks to add that the link to that PDF in the program for today, so that all the audience can get access to it. Thanks.
Great. Yeah, sure.
Thank you. I want to bring Sue and Steve and Monica back into this next question, because I think you all may have a perspective on it. Are there any special recommendations for screening transgender patients in your clinics? And particularly if they're on estrogens, do you do something different with breast cancer screening or any of the other screening things that you look at?
Yeah, I'll start.
Yeah, we'll let the man start, and then we'll let the women weigh in.
Well, I won't talk.
The man will start, and the women will give the correct answer.
There you go.
Yeah. True. So I wanted to mention that the IDSA guidelines do have a little section now on transgender care. So that's one resource. But, I've actually used the UCSF site, Trans Care. It's just a incredibly detailed site on transgender care. And there's specific recommendations for different types of screens, including for screening for breast cancer. And it involves not only age, but also kind of duration of exposure to hormone therapy. So I would, frankly, if you want more resources, I would look at that site. I'm sure other places have sites, but I've used the UCSF site.
Monica, maybe you can put the link to that in your response.
I will. Yeah, because this is a trans effort with our behavioralists and also our MDs at Ward 86 to put together these trans guidelines. So I think they are really helpful. We absolutely do age-appropriate screening estrogen will create a need for mammography. Also, we also screen in terms of osteopenia, osteoporosis earlier. So if you look at the bone guidelines by IDSA, there's kind of postmenopausal women or men over 50, but anyone on estrogen, we just start screening after 50, and we now have a DEXA screener actually at our hospital, which is really nice. We used to have to send them far away, and then the only other thing is clots, and being really. We did some things this year, like not give Johnson & Johnson, just sort of COVID vaccine with people, and for people who are on extra physiologic dose endogenous hormones, and because of the concerns for clots. So there were those are the three places where we change our recommendations for screening.
Sue, did you do anything differently?
Actually, I agree with Steve and do exactly what he suggested. I think it's maybe useful for the audience to know a lot of this is kind of a data-free zone. We don't have good data on any of it. The advice is very sound, but just be aware of that. And I think the other consideration that Monica was talking about the increased thrombotic risk is also a perfect area where smoking cessation becomes a very important conversation. And so I've actually tried to almost sort of like bribe some of our transgender patients that want more estrogen. It's like, well, you have to quit smoking, otherwise it makes me too nervous. The final thing that I've always sort of enjoyed is for people on gender-affirming therapy that are starting estrogen and finally get to the point where they need to have a mammogram, and they are just like so happy about it. And, you know, all of us women that have had mammograms know how miserable it is. And it's just sweet to see someone who's thrilled that they can get one.
Okay. All right. Paul, we have about 5 minutes left.
So this is a question that came in earlier about urine drug screening. And we heard that there are, some drugs that aren't detected. And so could you kind of very quickly summarize that again? Urine drug screening, oxy, buprenorphine, fentanyl are not picked up. How does one order the right screening test, Doug?
So the most important thing is to talk to your lab, right? So the lab is going to guide you on what you should order. So the point I was trying to make is that like buprenorphine as a synthetic opioid is tested differently in an immunoassay, the little kind of rapid test that you do, and it's going to look different than an opiate like heroin, morphine. So the key thing is not so much to memorize all of the various combinations, all the things that can cause a false positive or false negative. It's really important to talk to your lab. This is what I want to find. What's the test that I use? And then when you get a result, you're not sure what it is, make sure, like, why did my patient light up for this? What does it mean? Again, talk to the toxicology people in your lab. That's the most important thing.
Okay, thank you. So this may turn out to be the last question because I'm going to ask several people to comment on it because it touches on all of your talks and Monica and Sue. So can you comment on your recommendations, Steve, for healthy lifestyle in people living with HIV and how you implement those in your practice? So every one of you have said something about healthy lifestyle issues in your talk. How do you implement those in clinical practice, and what are the most important ones?
Yeah, well, I think part of, I think the first step is actually including it in your visit. Sometimes we're kind of focused on electronic record documentation and things like that, and trying to make sure people are up to date on immunizations and everything else, that by the time the visit's over, you've hardly even had a conversation. So I think, it's become a dominant discussion, I think, because of the prevalence of weight gain now in our population, including just for other reasons, but also a concern about ART and weight gain. So there are some, resources. CDC has some resources on healthy living and HIV. For people where obesity has been an issue, we have, gotten nutritionists involved. That's another approach and so on. But, I think a discussion of nutrition, exercise, and then focusing on some of the other healthy living things, tobacco cessation, limitation of alcohol, and so on. I might actually phone a friend and ask Kristine, because I think she's kind of an expert in this area as well.
So he just threw it to you, Kristine, so you get to talk.
Well, his office is right next to mine, so he can just come ask me when he needs to. But I think I've gotten in the habit of asking people kind of, are you still smoking? How much are you exercising? And just asking that, not even spending very long on it. But I've noticed that a lot of patients, I think, at least think about it. And then the next time they come see me, maybe it's not their next visit, but their next visit times 3, in a year or two when they come back and they've had several visits. But asking them each time, they're really excited when they come back and say, hey, I've been exercising 3 times a week for the last month. And so I think it's similar to smoking, where when you ask them about it and they at least think about it and that process starts going and they're considering maybe I should start, and then they make some decisions on their own, which is much more likely to stick. So I think simple questions, just kind of, what are you doing for this? And are you exercising? At least starts that conversation so patients think about it and know that you're interested.
Matt, critical for cardiologists. How do you get people to stop smoking and exercise?
Smoking is very difficult. I think for a number of reasons, right? I think for stopping smoking, but also for improving lifestyle in general, at least for me, my strategy is complete transparency always. And, ensuring there's no potential for self-blame or blame in any way, which I actually think is really important, because as soon as they start blaming themselves, then they start becoming reluctant to bring up anything because they're embarrassed about bringing up any suboptimal lifestyle related factors. And then we don't have the opportunity to address it. One thing I would say, this probably applies less for the smoking, but in terms of carrots and sticks, sometimes I'll use not really the threat of medication per se as a stick, but just to say there are a few things we know. We know if your blood pressure increases by 10 to 20, if your weight increases by 10 to 20 pounds, your blood pressure on average is probably going to increase by 5 millimeters mercury or more. If it keeps going at this level, you'll need medication for it, or you'll need more. Likewise, with certain dietary factors, what changes in diet can do to lipids, and how they may be able, initiating a more optimal lifestyle and diet pattern may help avert the need for medication, for statins, for instance, in the near term or medium term. I found that to be reasonably effective, but again, this is all anecdotal, and I think smoking cessation honestly blows all of those out of the water in terms of importance, and that's something that I still struggle with a lot with my patients.
Well, Sue, I think you get the last word. Any special tricks on healthy lifestyle advice for patients?
I don't have any magic tricks, no. But I do totally agree with Kristine that just talking about it and even officially recommending it, I kind of like the idea of writing prescriptions. Remember when we used to write prescriptions on a piece of paper, and then you could write them for, boyfriend has to do the washing up more, or something. And now sure you can't do that in Epic, but I think that there is some evidence, I think, from at least the smoking literature, that when a physician says to a person, I think you really need to stop smoking, I strongly recommend that you do, that can sometimes make a difference. And so I do tend to try to make as much use of that as I can, that from a point of view of how much we care about somebody, I really want you to do X, Y, Z, whatever it is, or stop doing something.
Great. So, Paul, I think it's time for us to wrap it up. I know there were still some questions left in our Q&A that we didn't get to in our effort to bring everyone into the discussion. So we will try to get those to the respective speakers and ask them to address them in writing or post them on our IAS-USA website as Q&A.